you, Mr. Speaker, sir, for the chance to contribute to this motion. I begin by congratulating the committee for having taken their time to go around the county and for having given us a report that largely exposes the failure of devolved healthcare. Mr. Speaker, hospitals are usually two institutions rolled into one. And this one, there's the catering services or the hotel services. Hospitals are hotels. There's a hotel component and there's a treatment component. And I would have loved the report to have segregated the two and then address them comprehensively so that you can isolate whether the main problem is on the medical side or on the hotel side of the institution. I say that deliberately because when they were unbundling functions and transferring them to counties, that question was not addressed. A hospital was looked at as simply an institution that did not have those very, very clear demarcations. And so, as much as it was possible to devolve the hotel sides, county governments can run hotel services. My question is, was clinical medicine devolved? Another question that I would like the committee to do is maybe to do some studies around the world, and in a system like what we have, a polity like Kenya, what are the viabilities of devolving clinical medicine? I look at the case of a doctor who has spent maybe 8 or so years training, and they need exposure. They need further training. They need to go for sabbaticals. They need all these things to keep abreast with the fast evolving medical world. Being sent to a county, what are the career opportunities of this person for growth within the setting of a county? If it's in Busia, when will he learn to deal with the challenges that may be in Moyale, the diseases that may not be in Busia? And if it's in Moyale, maybe how will he be exposed or she be exposed to these other terrains? So the litany of failure that I'm seeing in this report is an invitation to this House to take a deep breath and ask ourselves, why is devolved health not working? Two, why are personnel in health, especially the doctors, very, very frustrated and not motivated? Then we should also go further and ask ourselves, why would a hospital like Busia Referral Hospital have a pharmacy that is not stocked, but right outside the hospital you have got about 5 private pharmacies that are stocked, that if you did further interrogation, you might find they could be linked to people who work in the referral hospital? We could also go back and ask ourselves, why did the government stop branding its stores, medical supplies, gloves, and what have you? To a point whereby you cannot distinguish government stores from private stores. So it is very easy to pick a glove from a hospital and go and sell it in a private pharmacy because it's not branded. Why did the government stop branding medicines and other consumables that are used in hospital facilities? Could this be responsible for some of the big shortages we see? Because you see invoices, delivery notes, and all that, but there is no medicine in the hospitals. But the private pharmacies outside there are clearly well stocked. So I keep on wondering, would the situation stay the same if government stores were branded to insulate public goods from being stolen? The other thing I've heard people debate on this floor, and we have been unable to distinguish NHIF and universal health care. NHIF was never meant to provide universal health care. NHIF was an insurance package for civil servants initially, so that government could provide certain services beyond the basic medical care that everybody else was getting to the civil servants. It eventually grew and began taking up other people. And it was a membership thing. So to say here that SHA is providing universal health care, which NHIF had failed, is again another problem. Even the design of SHA is not for universal health care. The design of SHA is for paid up members. And SHA becomes just an enhancement of what NHIF later became when it was changed from the National Hospital Fund to the National Hospital Insurance Fund. So that only those who paid enjoyed the services. So if you want to get serious with the question of provision of health care, the national government must be involved right from the clinics. Let the county governments deal with primary health care. Let the county governments prevent people from falling sick. Let them keep people healthy. Let them spray mosquitoes. Let them run maternity hospitals, because maternity pregnancy is not a disease, it's just a condition. But where there is a need for intervention by a clinical officer, a trained medic, let that be the responsibility of the national government. Even if the hospitals, even if the county governments are going to retain the hotel part of the hospital, the clinical medicine part, the part that deals with treating people, the part that employs doctors, it's my submission, it should go back to the national government. Let us set up the National Health Commission that was promised in Naivasha to be established through legislation after the 2010 Constitution had been ratified at a referendum. 15 years down the line, the commission has not been set up. Doctors are being left at the mercy of small units called counties. Secondly, we cannot have every county setting up a referral hospitals with all the sophistication, all the expensive equipment, all the expensive personnel. Let us go back and embrace the national health referral system. And if I'm not wrong, in the 4th schedule to the Constitution, the national health referral facilities were left with the national government. They were never devolved. Policy and national health referral facilities, health policy and national health referral facilities were left with the national government. And I think if you look at sections, paragraphs 23 and 28 of the 4th schedule to the Constitution, they clearly show you that. Unfortunately, when the transition authority, whatever it was called, was transferring functions, it interpreted national health referral facilities to mean national hospitals. And so they unbundled things and took it down. Senator Mukatana has asked a very good question. Whether his governor could go down to his local hospital in Tana River, just as the good Professor Anyang' Nyong'o did with the hospital in Kisumu. What Senator Mukatana is not appreciating is that Kisumu already ran a provincial hospital under the national referral facilities, which it was given. Tana River did not get that facility. So already Kisumu was a center of excellence, even before devolution, serving a region. It had a level 5 hospitals, and I think it was at that level. But if you go back to some of these counties that hardly had a hospital, you may not be able to ask that question. When we come to the question of universal health care, universal health care cannot be provided using private hospitals. Because what is happening in this country is that the private sector is marching forward. Private hospitals are all over, but their motive is profit. If I look at countries where we have got proper universal health care, beginning with Britain, I think from 1948, you go to Canada, most recently you go to Thailand, look at their model. The first ingredient is functioning public hospitals. The hospitals are well run, they are well equipped, there's proper personnel, the environment is good, and the state then provides Medicare at cost. It only pays the salary of the doctors and other workers. It buys medicine in bulk. The medicine is controlled. It cannot just leave the system. Even here we had it. We used to brand our medicines. You could get a GK tablet. You can't sell it on the open market. So, in the absence of functioning public hospitals, it's a mirage to talk of universal health care. NHIF was looted not by public hospitals, but by private hospitals. They're the ones who inflated bills, they're the ones who manufactured things, they're the ones who subjected patients to unnecessary medical procedures. And today, if you go to any hospital, any private hospital in this country, you are like, and you have got a good insurance cover like the one, Mr. Speaker, you enjoy, you are likely to be taken through a regime of tests and even be put on bed rest, even be detained for 2-3 days, so that they can bilk the insurance cover, so that they can siphon money out of it. And so, SHIF, NHIF have similar designs running on private hospitals. And this is what we call, what neoliberalism has done. That's what structural adjustments did. That's what the IMF does. It reduces a government to a tax collector who provides no goods and services to the ordinary citizen. And so, Mr. Speaker, other than complaining about the sorry state of affairs in our hospitals across the country, maybe this House should bite the bullet and form a committee that can onboard various expertise and even do world tours to check out on how universal health care is provided. And then, from those who are successful, like Britain and Canada and Thailand, and I put in Thailand deliberately because it's a third world country with a very, very young universal health care policy that is working effectively, but that is it is funded by taxes. All you need to be is to be a resident of that country. If you happen to be not a proper resident, but you will be given emergency treatment if you are an undocumented alien. But here, where you are going to have a scheme whereby we don't have functioning public hospitals, and we are using premiums, and there's an insurance scheme, it's just going to be looted. And we have seen the reports coming saying that there has been a lot of looting of that scheme. I'm not saying it's a good scheme or a bad scheme. I'm not giving a merit judgment on the SHA and the social insurance fund, health insurance fund. I'm just stating that, good or bad, the money that is being raised from Kenyans is being stolen by private hospitals. And to stop that, we must fix our public health sector. We must get properly functioning clinics, dispensaries, level 3 hospitals, level 4 hospitals, level 5 hospitals, and the state must be involved. The national government must be involved because health is in the Bill of Rights. The Bill of Rights cannot be left, its enforcement cannot be left to one level of government. Under Article 6, the national government is supposed to provide its services on the ground. So let us see a situation whereby we relook at health. We set up the National Health Commission to deal with the human resource so that doctors can be taken care of, they can have chances to grow, they can be transferred from one county to another, centrally, just like teachers are transferred. And then let us go back and brand our medicine and government stores, other government stores and supplies, so that it is not possible to take a tablet or a glove or a syringe out of a hospital, a public hospital, into the open market. We have to do these small things, these small common sense things, so that we ring fence the public hospital, we put our doctors back, we equip these things and fund it directly with our taxes. The Abuja, Kenya is a signatory to the Abuja Treaty, which requires 15% of our budget to go to health. The last time I checked, we were doing way low, below 10%. If we were to put 15% of our budget into public health and do the necessary thing, and even including interpreting national health facilities, not to mean national hospitals, but also to mean a clinic in my village, so that the referral system can work. And by referral system, Mr. Speaker, sir, I mean that the centers of excellence like Kenyatta, the lower levels, level 5 hospitals, level 6, level 5, then level 4, then level 3, to the dispensary, to the clinics, are all intertwined and are sharing the limited resources, be it personnel, because some of these diseases require very high specialized training and are very rare. So that we are able to share these resources in a way that we do not invest too much in an area that we shall never utilize.
Give Senator OMUTATA 30 seconds to conclude on this.
Thank you, Mr. Speaker. So that you look at Mathare as a center of excellence for mental health. It's a level 4 hospital. It's not a center of excellence. It's not the level of Kenyatta, but it's a center of excellence of mental health. In my own county, skin disease in Alupe, a level 4 hospital. Spinal injury here in Hurlingham, a level 4 hospital. So when we talk of national health referral facilities, we must interpret them to mean the network of all hospitals, clinics, dispensaries that could deliver health care at cost and that could ensure we can have universal health care. The idea that counties should take over hospitals and maybe run them like silos is one idea that is very expensive, it's going to fail, it has failed, and let this House bite the bullet. With those few remarks, I support the motion, and I pray that the committee considers the amendment, the proposals are made so that the report can be enriched. Thank you, Mr. Speaker, sir.
Thank you, Senator OMUTATA. Senator Okenyuri Esther.